What is coronary artery disease? Well, CAD is when coronary arteries develop fatty plaques which restrict blood flow to the heart. And these fatty plaques are caused by a condition called atherosclerosis, which basically is creating fatty plaques in the artery walls. So now let's talk about atherosclerosis, which is the underlying problem. Atherosclerosis begins with injury to the endothelial cells that lines the artery walls. Possible causes of this injury include common risk factors for atherosclerosis, such as smoking, hypertension, diabetes, increased levels of LDLs, decreased levels of HDLs, and autoimmunity. And there's other non-traditional risk factors, which includes increased serum markers for inflammation, such as high sensitivity C-reactive protein, troponin 1, infection, air pollution, but those are like non-traditional. Injured endothelial cells become inflamed, and inflammation is fundamental for the progression of atherogenesis, and this is mainly because inflamed endothelial cells can make normal amounts of antithrombotic and vasodilating cytokines, so it makes it very difficult to respond adequately to injuries. The next step is when these inflamed endothelial cells express adhesion molecules. These molecules bind macrophages and other inflammatory and immune cells. Macrophages are activated by binding to damage associated molecule patterns called DAMPs. These are released from injured cells and release numerous inflammatory cytokines and enzymes, and therefore leads to more injury to the vessel wall. Toxic oxygen free radicals generated by this inflammation process cause oxidation of the LDL that has accumulated in the intima. This oxidized LDL causes more adhesion molecule expression, which then leads to the recruitment of monocytes that differentiate into macrophages, which then penetrate the intima and engulf oxidized LDL. These lipid-laden macrophages are now called foam cells, and when they accumulate in large amounts, they form a lesion called fatty streak. This fatty streak produces more toxic oxygen-free radicals, inflammatory mediators, and end up creating more damage to the wall. Macrophages also release growth factors, which stimulate smooth muscle cell proliferation, forming a fibrous plaque on top of this fatty streak. This fibrous plaque may calcify, protrude into the vessel lumen, and obstruct blood flow to distal tissues, especially during exercise, which may cause symptoms like angina or intermittent claudication. Many plaques, however, are unstable, meaning they are prone to rupture even before they affect blood flow and remain clinically silent. On the other hand, plaques that have rupture are called complicated plaques. Once rupture occurs, exposure of underlying tissues results in plate dilatation, initiation of the clotting cascade, and rapid thrombus formation. The thrombus may suddenly occlude the affected vessel, resulting in ischemia and infarction. Aspirin or other antithrombotic agents are used to prevent this complication of atherosclerotic disease. All major arteries are susceptible to atherosclerosis. When it blocks arteries in the limbs, it's called peripheral artery disease. When it blocks central arteries, it's called cardiovascular disease. And now that we are in the heart, when it blocks the coronaries, it's called coronary artery disease. There are two major forms of CAD: stable angina and acute coronary syndromes. In stable angina, an individual who has narrow coronary arteries may be asymptomatic at rest, but with exercise, they can experience angina, which is chest pain. When the person stops exercising and returns to the resting state, the angina will stop after a few minutes. To diagnose a stable angina, we can actually induce the symptoms of chest pain in a controlled environment and obtain evidence of ischemia as an ST elevation in the AKG. After we obtain this AKG, we reduce cardiac workload by resting the patient and taking another AKG, which in turn will show a normal AKG without that ST elevation. This is called an exercise stress test. Acute coronary syndromes. These are the most serious forms of CAD. They are life-threatening because of the unstable nature of the plaque. They are subdivided into unstable angina, acute myocardial infarction or MI, and non-ST elevation MI. When the obstruction lasts for only a brief period of time and no significant heart necrosis occurs, it's called an episode of unstable angina. If this ischemia continues and is persistent, it causes heart muscle death and ending up with an acute myocardial infarction or a non-ST elevation MI. An overview of the treatment begins with lifestyle changes as the first line of treatment. Like, for example, stop smoking, low fat, high fiber diets, exercising regularly, etc. Medications are also part of the management, and they're given to reduce the heart's workload and prevent blood clots. For example, B blockers, calcium channel blockers, ACE inhibitors, or antiplatelet drugs such as aspirin. When a patient's coronary arteries have already become significantly narrowed or obstructed, treatment may extend beyond medicines and require surgical reopening of the artery, called angioplasty, or bypassing the blockage with arterial or venous grafts.